Good afternoon. My name is Dr. Tony Lloyd. I'm the Chief Executive of the ADHD Foundation Neurodiversity Charity that is based in the United Kingdom. I'd like to thank the Kazim Trust who've invited us to offer you a number of short video film clips on the whole subject of ADHD. My particular wish today is to talk to you about assessment and diagnosis of children with attention deficit hyperactivity disorder. As you can see from this particular slide, there are some key facts that probably would be a good start for everybody to understand. ADHD affects 1 in 20 people, and it is a lifespan condition, but we know that children particularly experience more difficulty with it because their brains are still developing. Our brains don't fully mature until age 25. ADHD can impact on children in different ways, and it can continue to impact on adults across the lifespan, sometimes in certain contexts more than others. Historically, we've diagnosed many more boys than we have girls, but we're now beginning to realize that ADHD is perhaps as prevalent in girls and women as it is in boys and men. But we know that ADHD presents slightly differently in girls. Girls tend to appear less hyperactive, but not always. And girls mature quicker than boys, so are better able at masking or hiding some of their ADHD characteristics and internalizing them. And that can cause greater levels of anxiety and distress for young women and adult women. ADHD is not a behavioral disorder. There has been a long-standing myth that ADHD was about badly behaved boys. This is simply not true. ADHD is a neurodevelopmental condition. It's characterized by a neurological developmental delay that can be 2 or 3 or even more years in terms of certain cognitive competencies, certain abilities that we know children will need, particularly in a school setting. And for this reason, children with ADHD sometimes appear less mature than their peers. And this is where perhaps some of the confusion has arisen around this idea that ADHD is a behavioral disorder. Early identification, diagnosis, and treatment of children with ADHD is proven to significantly improve their life chances across a whole range of indices. We know that the earlier we identify and support children, the less likely they are to be vulnerable to mental health problems such as anxiety, depression, post-traumatic stress disorder, eating disorders, addictions, and things like obsessive compulsive or oppositional disorder. There are 3 core characteristics to ADHD, and they are hyperactivity, impulsivity, and inattention. Now, we all know that all children can be hyperactive at times, they can be impulsive, and they can also be inattentive. Children's brains are growing and developing all the time. And I mentioned that they don't reach maturity until mid-20s. We know that it's important for assessing ADHD that we look at these 3 core characteristics, that we know that there has to be at least 2 of them in order to meet the diagnostic criteria for ADHD. We know that some people present simply as impulsive hyperactive, some people present as inattentive hyperactive, some people present with a combination of all those 3 characteristics. But when clinicians are assessing a child for ADHD, they will look at other secondary characteristics. And these include impaired executive functioning skills. And I'm going to talk a little bit more about those in a moment. We also look for low emotional resilience or emotional dysregulation. Children who are easily distressed, easily frustrated, um, sensitive to rejection or hurt, and experience difficulty in managing their emotions in certain situations and certain contexts. We also need to consider the frequency and co-occurrence of other learning differences or learning difficulties, such as dyslexia, which affects over 40% of those with ADHD, autism, which we know can co-occur in up to 30% of children with ADHD, but also dyspraxia, dyscalculia, and tics or Tourette's. We know that many children with ADHD experience tics at some stage in their lives, many of them in puberty and adolescence, some of them sometimes when they're either first starting medication or sometimes transitioning off medication. We also know that children with ADHD are vulnerable to things like anxiety and depression, as I've mentioned. So it's important that we look at the child holistically and not just focus on those three core characteristics of hyperactivity, impulsivity, and inattention. So a quick summary here of the key points about ADHD. We know it has a global prevalence of around 5.26%, according to the World Health Organization. But we know that in some communities and in some cultures, this may be higher than 5.26%. It's a polygenic disorder of self-regulation, and it is genetic in origin. But genes are only part of the story. The genetic expression is affected by our early environment as our brain grows and adapts to the environment that we live in as children. And we know that children who are born in very stressful environments, who experience trauma in childhood, that their ADHD may present in a more severe or pronounced way. ADHD is highly heritable. We know it runs in families. It's not necessarily certain that either or both parents would have ADHD, but it is often very likely. We know that in about 1 in 5 cases, ADHD can be caused by traumatic brain injury. And we see this most commonly in children who've had seizures or who suffer with epilepsy. But we do know that very severe sleep deprivation in early childhood can be a factor that triggers that genetic expression. Symptoms or characteristics have to be evident and pervasive across 2 domains, 2 settings, so at home and at school. But they will be slightly different because the kind of things that we ask of children in school are different from what we ask of them at home. So we need to be clear about exactly what we're looking for and what information we are asking for from teachers and from parents when trying to assess whether a child meets the diagnostic criteria for ADHD. The genes involved in ADHD are genes that every human being has. But in ADHD, these genes present or express themselves in a more pronounced way. So we know that there is a genetic cause, but we know that environmental factors will influence the expression of ADHD. We know there is an increased risk of ADHD if children are born preterm. And we also know that severe perinatal trauma or assaults during pregnancy may be triggers that will create the gene expression that would mean the child meets the criteria for a diagnosis of ADHD. We know that there are very significant genetic overlaps with autism. We know that cognitively, The key concerns are differences in the neurotransmission of dopamine and norepinephrine. And we know that norepinephrine, of course, derives from dopamine. We also know that in girls, estrogen is a precursor to dopamine. So we know that there may be certain days in a menstrual cycle where girls may experience more cognitive difficulty. And we know that in adult women, that may also be the case, and particularly in menopause and perimenopause. We know that ADHD and the neurodevelopmental delay associated in certain parts of the brain will impact on the frontal cortex, the limbic system, the basal ganglia, reticular activating system, and the cingulate gyrus. And we know that the poor synthesis of these neurotransmitters tell us something about how certain medications work or improve cognitive function and reduce the impairment that we know is associated with ADHD. I mentioned before that executive functioning skills or poor executive functioning skills are very common in many, but not all children with ADHD. And these executive functioning skills comprise of these key competencies: working memory, the ability to hold information in mind while you problem solve and make decisions about how you respond to your environment. Flexible thinking, being able to adjust our thinking and deal with unexpected changes or demands that our environment is asking of us. Being able to regulate our emotions, keep our emotions in check so that we don't always respond emotionally, but we know that for children, their emotions are always in the ascendant, their brains are developing, they are driven primarily by a need to feel safe and protected by their primary caregivers, and only when they feel safe and protected are their brains able to learn, because anxious brains do not learn. Anxious, unhappy children are not successful learners. Impulse control is another executive functioning skill. Now, all of us, when we are under pressure, will have some difficulty controlling our impulses. Impulsive behavior could be things like interrupting people, not looking when we're trying to cross the road, and not understanding the potential risks or dangers. It might even be impulsive spending. Impulsive behavior can present in many different ways. Another executive functioning skill is task initiation, being able to start a task and not procrastinate. ADHD is often associated with lateral creative thinking, and sometimes children will struggle to know where to start a task and will need these tasks breaking down into small manageable chunks. And because they have often poor working memory, then it's important that if we're going to give children instructions, that we repeat them, we ask them to repeat them back to us so we know they've understood. And ideally, we also write those instructions down so that children are able to remember them. Don't always assume that if a child is not following instructions, that they are deliberately choosing not to follow instructions. Quite often it's because they have not heard or processed what it is that is being asked of them. Learning how to plan and prioritize tasks is another feature of executive functioning, and so is the ability to self-monitor ourselves so that we understand how we feel and how we are responding to our environment. So ADHD is a neurodevelopmental condition. It is evident through attentional dysregulation as opposed to attention deficit. ADHD in attention is not because you can't focus or concentrate, it's because you can't filter out a lot of other stimulus. It's a bit like watching a television and there are 6 televisions on, but you're only trying to focus on one. It's difficult to filter out the other 5. So it's attentional dysregulation, impulsivity, hyperactivity, potentially poor executive functioning, poor working memory, and developmental delay. Now, Poor executive functioning skills can look like this. So poor impulse control may look like saying or doing inappropriate things or behaving in ways that might present risks without having considered what the potential consequences might be. Emotional control, which is about being able to describe our feelings and manage them. In ADHD, that can be overreacting, becoming easily distressed or frustrated. Flexible thinking, being able to adjust to the unexpected. Some children will get frustrated and struggle with that sudden change. Working memory, I've mentioned, can present as trouble remembering instructions. Self-monitoring, being able to judge how you're doing. Children with ADHD can sometimes be very surprised if they don't get the outcome they expect and get very upset. Planning and prioritizing, deciding how to set goals, how to plan goals, how to time goals, is also something that children with ADHD might struggle with. So for them, it might be difficult for them to decide what is the most important task or how to complete a task, or even task initiation, how to start a task, knowing where to begin. And losing train of thought as well as possessions, forgetting things, losing things. All of these are typically executive functioning impairments. Now, ADHD rarely travels alone. I mentioned before it frequently co-occurs with dyslexia, dyspraxia, dyscalculia, tic disorder, Tourette's, and autism. So when we're assessing a child for ADHD, it's important that we don't just look at the ADHD core characteristics, that we also ask the school, the parents, and if possible, screen for other neurodevelopmental conditions like these, because all of these will contribute to the degree at which the child is experiencing an impairment and therefore unnecessary mental distress. You can have sub-threshold traits of autism, dyslexia, so you might only ever have one diagnosis, but it doesn't mean you don't have those other difficulties. So it's important that we look at the child holistically and understand their needs holistically and not just from the diagnostic criteria solely for ADHD. It's imperative that we don't forget or under-recognize or not support children who appear to be sub-threshold. They may have many difficulties that are sub-threshold. They may be very good at masking their symptoms or characteristics, and we see that particularly in girls. So the diagnostic criteria for inattention is fails to give close attention to details, difficulty sustaining attention in tasks or activities, easily distracted, does not appear to be listening when spoken to directly, appears to fail to follow instructions, forgets things that are needed to complete a task, makes careless mistakes with written work. With hyperactivity, it is boundless energy without direction, fidgeting. We know the body's natural way of producing more dopamine is to move. So it's important that in school and in lessons, children are allowed to move in a structured and safe way, because that is stimulating the production of dopamine and improving cognitive functioning. It's improving concentration. Children learn better when they're moving. And that's why children with ADHD who have difficulty synthesizing dopamine are more inclined to be hyperactive. So they can squirm, they can find it difficult to remain in their seat, they can climb on things, they're unable often to play quietly. It's almost as if they're driven by a motor. They can talk too much, sometimes have difficulty sleeping or getting to sleep. The diagnostic criteria for hyperactivity impulsivity is the child who blurts things out prematurely, who shouts out the answer, who finds it difficult to wait their turn or be in a queue. They can interrupt or intrude on others, and they may find any tasks that require stillness very challenging, and they need to learn how to challenge that energy, because hyperactivity can be a real asset. It doesn't have to be a disadvantage. It can be challenging for parents and adults around hyperactive children, but hyperactivity in children can be a positive, can give them lots of energy. Hyperactivity in adults can certainly be an asset. Equally, with impulsivity, it can be decisiveness, quick thinking. So there can be some positive elements to impulsivity. Context is, of course, important. And the diagnostic criteria, of course, is that impulsivity to meet an immediate need. Children are very good at delaying gratification. They're often led by their feelings. They want something and they want it now. They don't necessarily consider the appropriateness of their behavior or actions or words, or indeed the consequences. So they often make decisions on the spur of the moment. They can make the same mistake over and over again, failing to check their work, or sometimes racing to complete a task or a piece of work in school, and then find that they've got time left, but they've rushed that piece of work and it's not anywhere near representing what their ability is. And they can, of course, misrepresent or misinterpret rather facts. They can misread text because they are moving, or their brain is working too quickly, and sometimes their brain works much more quickly than their handwriting, so they can leave clumps or sentences out of a paragraph so that the work doesn't quite make sense. So best practice models of assessment and diagnosis are: identify children early, ask the parents whether or not was the child born prematurely, was there any birth trauma, has there been any seizures or epilepsy or any brain injury, and let's eliminate any other of those risk factors straight away. It's important then that the child is assessed using something called ADHD rating scales. These are questionnaires that we observe the children's behavior. The parent observes the child's behavior, and the teacher observes the child behavior. But there are some doubts about the quality and accuracy of those observational questionnaires, because sometimes the parents and the teachers are looking for different things, or there is an unconscious bias. They're looking for something in particular, and that is therefore what they see. There are a whole number of rating scales like SNAP, Vanderbilt, Connors, that can be used by parents and teachers, but also clinicians sometimes complete these themselves. Increasingly, we are seeing much wider use of objective, computer-based, quantitative, cognitive screening tools like QB Test and QB Check, because they are over 80% accurate, and they give us a report on the child's cognitive function, whereas the observational rating scales tell us about observed behavior. And sometimes what might look like ADHD, in fact, is not ADHD. So we know that any child who is in very acute distress might present like they have ADHD. The difference with ADHD, of course, is that ADHD is there pretty much all of the time. So some of the challenges or concerns about the observational rating scales are these. How knowledgeable is the observer, be it the parent or the teacher, in terms of ADHD? What are they looking for? Are they looking for bad behavior or classroom inappropriate behavior? Or are they looking to discern whether or not there is a cognitive impairment, i.e., all those difficulties that we've just talked about before in terms of executive functioning skills, concentration, memory, learning, impulsivity, etc.? Is there a lack of understanding about the natural variations in neurocognitive capacity? Remember, children mature at different levels. This is not just about, are they succeeding in school? Children develop at different levels. Children have different levels of ability. And sometimes whether a child is succeeding in school can be the outcome of many factors, not just ADHD. And teaching professionals really do have to ask themselves, before they start saying, well, there is something medically wrong with the child, ask yourself, how can you adapt your teaching? Or as a parent, how can you adapt your parenting to enable and support your child? And not make assumptions that if they're not doing as they're told, or they're not achieving in school, that automatically means that they have ADHD. Again, Think about gender bias. We know that girls present often as less hyperactive, they mature quicker and more compliant. So are we overlooking girls completely? Do teachers and parents understand when they're completing rating scales that other learning difficulties like dyslexia, dyspraxia, dyscalculia may be impacting on the child's ability to learn or understand or speak and act appropriately in a school or a home context? Don't make assumptions that all children's behavior is chosen and intentional. It isn't. Children are often led by their emotions and are often impulsive. All children are. With ADHD, we need to know that that needs to be at above a certain scale. Don't over-medicalize the child. ADHD affects 1 in 20 people. It's very, very common. It's been around for as long as human beings have. Also, ask the parents and the teachers whether they are aware of any adverse childhood experiences, any traumatic events, which might also be explaining why the child is behaving the way they are and why they might be underachieving in school. I mentioned computer-based quantitative cognitive functioning tests because they, combined with those observational rating scales, give us a far more accurate understanding, not just of whether the child has ADHD, but how the ADHD is impairing that child. And this is a simple computer-based test that can be used in a clinic setting, and there is a school version called QB Check. These are really valuable tools if you're trying to make a quality assessment for ADHD. This is the kind of report that you would get from a QB test. And if you look on that screen, you can see an example of an ADHD cognitive profile. And if you look at some of these squiggly lines on the top, that's the hyperactivity that's measured. And then all the other dots and graphs will tell us about performance in terms of cognitive functioning, speed, reaction, impulse, and attention. And the report that you can see on the other side of the screen is the impact of medication for ADHD on this child's cognitive functioning. I'm going to talk a little bit more about medication and treatments in a moment. So, when we're talking about treatment, we know that by far the most effective treatment for ADHD is stimulant medication, so methylphenidate, lisdexamfetamine, etc., and non-stimulant medication equally. So stimulant medication has an effect size of 0.9, non-stimulant medication has an effect size of 0.8 out of a maximum of 1. Now, we know that certain diets may help children. We know that reducing food colorings may help. We know that neurofeedback, biofeedback may help. But these things are not particularly efficacious in terms of the lasting impact. Nutritionally, we know that omega-3 supplements are an important nutritional supplementation for children with ADHD, because we know that children with ADHD have difficulty metabolizing long-chain fatty acids, and your brain is made up of 60% long-chain fatty acids. So I would strongly recommend omega supplementation for children from a very early age. But behavior parent training is not as effective as a lot of people think. Often it's about helping parents to understand what ADHD is, what it isn't, and then therefore to better understand their child and be able to parent their child in a more loving and effective way. But by far, medication is the most effective intervention. And we know things like cognitive behavioral therapy can also be very helpful, particularly when it's used in addition to ADHD medication. And I think the point we need to make here is, when you're giving a diagnosis or getting a diagnosis, it's important that you explain exactly what ADHD is and what it is not, and that medication is not a neurological pill that's going to change children's behavior. It's not a morality pill. It improves cognitive functioning to such an extent that it can reduce a lot of learner anxiety in children. It can reduce some of that impulsivity and hyperactivity. So obviously they may appear to be behaving, but actually the cause is it's just that their cognitive functioning is working more effectively with medication. But we strongly advise that treatment should be multimodal. It's not just about medication. It is about healthy lifestyle choices, good diet, particularly a breakfast in the morning, whether they feel hungry or not, because brains need food, but also things like good sleep, and parents who are informed and who know how to parent their child in a loving and compassionate way. So I've mentioned before about omega-3 supplementation as one nutritional supplement, and we know that, again, used as an additional treatment alongside ADHD medication can be particularly helpful. There are 6 crucial strategies we need to be advising anybody with ADHD, and that is understand what ADHD is and what it isn't. Understand that self-care, learning how to self-soothe, self-calm, have a healthy lifestyle, get enough sleep, get exercise, have good nutrition is equally important. Get support for your executive functioning skills, particularly in school. Ask for teaching strategies that facilitate how to plan and execute a piece of work for the child. So scaffold that work. Children with ADHD are often visual thinkers. They need diagrams, drawings, mind maps. So it's important that the school understands how to teach children with ADHD, because if they don't, they can potentially do more harm to the child's mental health by causing them unnecessary mental distress. When it's not that they're lacking in intelligence or ability. We know that over 30% of business owners and entrepreneurs have ADHD or dyslexia or both. We know there are many successful people with ADHD. So we need teachers to understand that children need to be taught in a slightly different way, in ways that will benefit the whole classroom. Another key of these 6 interventions is helping children to learn emotional regulation, and that is about daily stress reduction and self-calming strategies every day, so it becomes a habit. And whether it's in school or in work, help children learn to understand how to play to their cognitive strengths, so that ultimately they can really develop and flourish in those areas of learning and cognitive competencies, where we know that they will thrive. Assistive technology, particularly on smartphones and in laptop computers, can be very helpful to any child with ADHD, and especially if they have co-occurring dyslexia, for example. And finally, we would say celebrate neurodiversity. Let's move away from this idea that there is something wrong with the child, that, we don't over-medicalize the child. We don't abdicate responsibility for helping a child and nurturing a child and teaching a child and parenting a child and enabling them to achieve their potential by putting all the responsibility on the doctor to do something about it. It takes a village to raise a child. We need children to learn to understand ADHD for themselves and learn how to manage it for themselves as they mature into adults. But let's recognize that ADHD has been around for as long as human beings have, and like dyspraxia, dyslexia, autism, dyscalculia, there must be an evolutionary reason why 1 in 5 people have these different types of minds that in our schools we have often mistaken for low ability and low intelligence. ADHD, like dyslexia, dyspraxia, dyscalculia, does not correlate with low intelligence. So if a child isn't achieving, we adapt how we teach, we adapt how we parent. And finally, just to let you know that there is a whole range of free e-booklets that are available on the ADHDfoundation.org.uk website There's a booklet for teachers on teaching and learning strategies. It's free for you to download. There's a booklet for parents. There's a booklet for children, a booklet for teenagers. So please use those resources to help you. Please share those resources with other clinicians, teachers, other children, other families who may be impacted by ADHD. Thank you very much indeed. It's been a pleasure talking to you, and thank you very much to the Kazim Trust for the work that you do in psychoeducation, but also in providing treatment and therapies for children with ADHD. And I wish you all well in the work that you do. And thank you for the opportunity to support you with what you do. Bye-bye.